Your slides look good as well.
Thanks, Danielle. Yeah, so today we'll talk about a drug class that is one of the older ones, and it's really kind of the classic chemotherapies, cytotoxic agents. These have a lot of adverse effects. Every time we really celebrate when like a disease can be treated without chemotherapy. This year, it's really exciting. Just last month at PRMC, we reviewed a regimen that is a non-chemotherapy regimen for breast cancer, frontline breast cancer. And so it's always exciting to hear that. That said, there's still several cancers that are cured with cytotoxic agents. So testicular cancer, colorectal cancer, breast cancer, and lung cancers among the larger ones. So it's important to know these agents and the adverse effects and how to treat them. So for today, we'll talk about mechanisms of action, adverse effects, supportive care strategies, and then I'm going to talk a little bit, just a few slides on investigational drugs and oncology genomic tips, especially from kind of the pharmacy point of view. We'll start with alkylating and platinating agents. And this was really kind of wartime history. This research was done on sulfur gases during the World War II. They had seen effects on individuals, and that lymph tissue was heavily depleted. And the Goldman and Goodman studied this at Yale, and were able to develop a molecule, meclorethamine, that we really used until recently. Even 10 years ago, we were still using it. That takes advantage of alkylating agent principles. There's 7 different types of alkylating and platinating agents, and it's really kind of a history of science and a lot of different ways to get to these different classes, which is really interesting to see. So sulfur mustards, analogs, essentially making that sulfur mustard more stable, less toxic over time. Azuridians were really a rational, like mathematical, physical design around a azuridium cation. And alkyl sulfonates were developed just straight up chemistry. Nitrosoureas were a random National Cancer Center screening that showed weak activity. And so they were developed to be better cancer drugs. Triazines were initially developed as antimetabolites, but found out to be alkylating agents. And then methyl hydrolysines had anti-cancer potential found during cytotoxic screening. So these are developed as psych drugs, but they discovered they had cytotoxic effects. Platinating agents were in California, discovered at Linus Pauling, actually. And so one of the most commonly used cytotoxic agents came out of biophysics research. Here are the 15 drugs we'll talk about in the alkylating and platinating class. 6, really kind of know the ones highlighted in green. So 6 of the agents are given more than 500 times per year. And then 5 of the agents are given to at least 100 patients per year. So you can see cyclophosphamide is the most commonly used alkylating agent. The mechanism of action, so essentially, it has to be at physiologic conditions, and essentially a nucleophile of the DNA attacks the azithromycin portion of the molecule and ends up forming a covalent bond. And it is really the same for both the platinating agents and the alkylating agents. After these bonds are formed, several mechanisms happen. So there's either fragmentation of DNA and RNA, mispairing of nucleotides, and oftentimes when you mispair the nucleotides, you'll have a stronger bond. So you can see alkylating guanine thymine has 3 hydrogen bonds. It's more stable, even though that's not biological. That's a mutation that will be deleterious long term. And then cross-linking of the DNA to either interstrand, or to proteins that destabilize the cells. There are 30 black box warnings for alkylating agents. It's one of the highest of any class. On this diagram, I really I went head to toe on the adverse effects. And then if it's a black box, that is a black box warning. If it's an X only, that's a package insert warning or precaution. So not a black box, but a package insert warning. And then the blue are the platinating agents. So you can kind of see class effects with the platinating agents. There's a fair amount of like neurotoxicity as a class has a fair amount of different adverse effects, a variety of them. And then on the right-hand side in yellow, if the adverse effect is in 4 or more of the drugs, I highlighted that as well. Neuro-wise, like encephalopathy will hospitalize patients on ifosfamide. Pulmonary toxicity, busulfan is a drug that is actually directly toxic to the lung and can have long-term impacts on patients. Cardiotoxicity is seen in a number of agents, hepatotoxicity, veno-occlusive disease, which we'll touch on briefly. And then GI has, nausea is kind of a classic chemotherapy effect. Next page here. So the red ones are 10 or more adverse effects highlighted. So myelosuppression is a class effect. Every single one of these drugs is going to cause myelosuppression, often severe. Secondary cancers are, one of the main reasons we like to get away from these drugs. So we were really excited to get, APML therapy being a non-chemo based regimen about 7 years ago now. And we just haven't had secondary cancers from the previous therapy that we gave. Before that, we'd have, 2 to 3% of patients would have secondary cancers. And then hypersensitivity is a class effect as well. So we'll talk today just about how to best manage that and look at it. You'll see infusion reactions are not super common in these drugs. So more often than not, if one of these is going in, it's a hypersensitivity and not an infusion reaction. Not always, but it's a good rule of thumb. And then on the bottom, you'll see black box warnings for experienced provider, and there's any number of reasons for that. Oftentimes, patients have to be hospitalized to safely administer these drugs. And then finally, the medication error prevention is lomustine wafers, which are really given every 6 weeks, or oral too. And so there's been errors with patients getting refills and taking that more commonly than every 6 weeks. So that's the black box warning there. Okay, so I'm going to kind of go by go head to toe, but we'll start with some whole body side effects. Neutropenia. And so as you saw, cyclophosphamide, the most commonly used drug, this is really why it just has a really clean, happy neutropenia profile. So we can really confidently tell breast cancer patients or lymphoma patients that every 21 days you're going to get your therapy. The onset of neutropenia is very clearly a week, and almost always the nadir is 10 to 14 days. So it's a very clean drug. It's metabolized across the human population very similarly. And so that's one of the reasons why it's so commonly used. Melphalan is largely used in the bone marrow transplant setting. And you can, the effects of this neutropenia are why. So melphalan doesn't necessarily deplete immune cells like fludarabine or cyclophosphamide would. It is really good at penetrating the bone marrow and clearing the space there. And so allowing the transplanted autologous cells to find a niche and find a place to stay. They have almost 5 full weeks to get there with melphalan. And so that's one of the main reasons that melphalan is used in transplant. And it's the most common use of melphalan now. We hardly ever use it for other indications now. This is a NCCN guideline. And so febrile neutropenia, we base it on risk. So if given the therapy and no growth factor support, if they have 20% or higher of febrile neutropenia, we call it a high risk. Intermediate would be 10 to 20%, and low would be less than 10%. And so you can see that a big chunk of these regimens include an alkylating agent. And across all disease types, bladder cancer, breast cancer, esophageal, lymphoma, soft tissue sarcoma. When you highlight the drugs on the table like that, it really stands out. So growth factor treatment. So all of the regimens that we build, there's over 1,500 beacon treatment plans now that we have built, and every time we build one, we assess the baseline growth factor needs. And so they'll either be like built into the plan and stated as growth factor necessary or growth factor needed, or it will say consider growth factor for the immediate risk regimens. And so if you have somebody come into the ER that had a fever, we want to make sure, see if they've been on growth factor or not. If they have been on short acting, plan to resume it. And if they've been on long acting, it generally lasts 14 days. So if it's been less than 14 days, we would not continue it. And if it's been more than 14 days, we will occasionally consider starting growth factor. So secondary prophylaxis is a little bit more, it's actually like pretty well defined. IDSA, NCCN, a couple different places have guidelines on this. But if an intermediate risk patient did not get growth factor, went home, and then came in with neutropenia, you'd really look at these indications. If they're over 65, if they have sepsis, if their ANC is 50 or 20, if they've had neutropenia for more than 10 days, or it's expected to be more than 10 days, pneumonia, invasive fungal infection, hospitalization at the time of fever, so they're in the hospital for something else. And then a prior episode of neutropenia fever, we almost always would add prophylaxis at the next regimen. And then after this admission, like we would look at antibiotics and growth factor support for the next cycle of therapy and beyond. So this is spelled out in both the clinical practice guideline and a neutropenic fever admission order set. If you're interested in saving that, it's 1604. Oftentimes it's nice to have these as favorites to reference. I find that nowadays in HealthLink to be the easiest way to look at these things. All right, so we'll pivot to chemotherapy-induced nausea and vomiting. And here's another table that kind of highlights again how much these agents make up the higher adverse effect profile of these drugs. And so it's the same thing. Every 3 years, the physicians and pharmacy department look at the what we're giving for preventing nausea and whether or not these regimens need updates or not. And here, this table helps guide us. So high risk would always get, fosaprepitant. Basically a 4-drug cocktail. You'll get fosaprepitant, ondansetron, some sort of steroid, and olanzapine. And so when I was first learning, like, is it a high emetic potential chemo regimen or not? Like, you really kind of can just look to see if they're getting a prepitant or fosaprepitant, and then you can be pretty comfortable that it's a high risk regimen. Again, every 3 years we build this into the plan, and so you don't really have to think about it, but you certainly should know about it. And there can be minor adjustments, like some people, in this case here, like the patient didn't tolerate ondansetron due to severe headaches and switched it out for palonosetron, which is a little bit better profile just because the peak is lower. There's several guidelines, so we follow, all 3 of the major guideline updates that are not always every 3 years, but in our 3-year review of CINV, we're looking at the latest guidelines. The health effects for you is pretty decent for nausea in cancer. And then some tips for managing nausea is, so temozolomide is an oral chemo, will alkylating agent. We'll tend to give that at bedtime on an empty stomach, and that helps with nausea. With the same drug, we use low dose ondansetron before each dose, so 4 milligrams. 30 minutes later, take temozolomide. Before we did that, we had a couple admissions to the hospital for nausea and vomiting. So ever since we changed to the pre-medication schedule, that we haven't had admissions to the hospital. Adequate hydration, and some patients will, especially like a high dose cisplatin for sarcoma, they might need a therapy plan, like a couple, 2 boluses a week for the week after chemo, for instance. And so you can put that into the supportive care plan of Beacon. We might have to increase the antiemetic prophylaxis for future cycles. So if they had moderate emetic plan, like with just Zofran and steroids, we would add fosaprepitant the next time. If they had the high risk regimen, we could, prolong the olanzapine, prolong the steroids. And then in palliative chemo, or refractory chemo, we do consider dividing the doses a little bit. We don't do that super often, but we have had some luck with that if it's more of a palliative setting. All right, so now I'll go head to toe on this in this class. So and just really pick out 1 or 2 toxicities from the system. So for ifosfamide, this drug has been given less, which is really nice. We have a lot more agents that have been able to replace this in lymphoma and in sarcoma, but it is still sarcoma is still commonly used, and once in a while we'll give it in lymphoma. And so here the kind of the classic picture is a totally normal dude, like they had a high level job, they're thinking quite well, and then the next day they'll totally change mentally. They'll be aggressive towards their family or staff, or be just totally somnolent and not engaged. And it's really comes on pretty dramatically. It almost always associated with a risk factor. So their tumor might be involved in their liver. They might have poor nutrition status, so their albumin is low. And usually they'll have more than one of the risk factors noted at the bottom. So they'll have like kidney injury plus, low albumin, or low albumin plus prior CNS disease. It's almost never just one of those. So the onset, we'll keep people in the hospital for a couple hours after to make sure really a day after, to make sure they're tolerating, and 12 full hours of fluid after the dose is infused. These are long infusions. And but yeah, it's generally we see this within 2 hours to 48 hours. It's very rare to happen later, but it has happened. I would say that happens maybe once every 10 years, where it's like outside of the 96-hour window at least. So to treat this, you would stop the infusion, immediately. And let's see, we restore the metabolic pathway for chlorella. So it's electron transport mechanism issue. And this dose will give, stop the treatment, or stop ifosfamide, and generally start methylene blue, unless you're thinking, if you've ruled out like a sepsis picture or some other cause of the ultramilk status, then start treatment. This can be a little slow to, like, you hope it would work right away, and it really doesn't. It usually takes a couple days to get out of this. I've only had one like refractory case where it was just kind of like it was a patient that was really didn't have any options left, but didn't have great kidney or liver function, and still treated with ifosfamide, where they just had terrible encephalopathy that did not respond to methylene blue. Most of the time it does eventually work. And yeah, I would say, closer to 36 to 48 hours for recovery time. This is a medication that looks like this when you after methylene blue administration. So you let patients know their pee will be blue. The second adverse event is peripheral neuropathy, and so this is most commonly associated with the platinum agents. Acute, about 2/3 of patients on oxaliplatin will have it. It is reversible, usually within 14 days. So usually by the next time you have chemo, the patients are out of the weeds for this. It can happen within hours. Usually it's about a day or so after the drug is given. It almost always comes back. Sometimes often, I guess, it's worse with subsequent cycles. So it might get better resolved by day 9, the first cycle, then day 10, day 11, and it can be a dose-limiting toxicity. So if people cannot, put on clothes or open jars or brush their teeth because of severe neuropathy, it really is a challenge. Then persistent, which may not be reversible, people have this the rest of their life. So paresthesias, dysthesias, hypothesias, and it can also affect activities of daily living. I've had, there are some patients that are very, I've had knitters that have been really distraught with this adverse effect. They'd said they'd rather not have chemo than not be able to do their hobby. Artists as well have complained a lot about this, but it is something to take very seriously. And it has been looked at significantly. It's one of the most studied adverse effects in cytotoxic chemotherapy, if not the most. So a lot of things have been tried and failed. We do have some evidence for duloxetine. The platinum agent pain favors duloxetine. It's less so for the taxanes, but for platinums, it probably does help some. And even if it cuts the pain 20 to 25%, sometimes people really respond to that, and it's enough to kind of improve their quality of life a lot. So it's certainly worth a try. Generally, it'd be 30 milligrams for 7 days and then go up to 60. Then the second strategy is dose delay, reduction, or stopping. And that's sometimes used more, again, generally in the palliative setting, where FOLFOX might be stretched out a little bit. There's not great handouts for peripheral neuropathy. It's just such a complex adverse effect. It affects different patients based on their living situation, their hobbies, how they get around. And so I think just the message here is that this handout is a more of a novel or a longer read for patients, but it's probably best to have more information than less. It's not just the fingers and toes. You can have calf muscles affected as well. So people walking downstairs will be less weak at certain times. So it's an important adverse effect to counsel on. And this again is we love to get away from chemotherapy-based options when we can, to minimize this adverse effect. But some good tips here. So like some people will apply grab bars. You have to be really careful with hot water because you won't sense it. Wear rubber gloves when you're washing dishes. Really careful with steps. Consider walkers. All these are really, really good ideas. Watch the shoes. Okay, so moving down to lung toxicity. This is the one I mentioned, the first chemo agent having pulmonary toxicity described, and their metabolites of busulfan are known pulmonary toxins. This is rare. It's less than 5%, probably less than that. I'd say, I kind of, working over the years, I'd say 1%. But it also occurs with other alkylating agents, but less common. Symptom are just kind of miserable, like these low grade, not like, not super life altering, but pretty like noticeable cough, shortness of breath, fever, and then it really kind of advances and just doesn't get better over time. Really long onset. So this is not common for an adverse effect due to alkylating agents, but it's certainly there's several adverse effects like this that'll happen 2 years after, 4 years after, even 5 years after. Some of the secondary cancers can happen 5 years later. And so generally, really working closely with the pulmonary team, consider we consider steroids. It generally has not been super helpful. In general, there really more needs to be done to figure out how to respond and how to appropriately treat this adverse effect. Cardiotoxicity, I just wanted to highlight just the kind of the wide variety of adverse effects. And again, cytotoxic agents are broad. They affect all cells. So arrhythmias, cardiomyopathy, like early on, breast cancer was treated with bone marrow transplant, and the dose of cyclophosphamide was 90 milligrams per kilogram, which ended up causing 5% of heart failure in patients. So that was how that was detected. A lot of times these are dose limiting toxicity effects. So the doses have been modified down over the years. Heart block, we've seen that with really any dose of cyclophosphamide. It's usually a first degree heart block. Hypertension, myocarditis, and QT prolongation. So pretty much, a wide variety of cardiovascular. So veno-occlusive disease, which we talked about earlier, it's again probably closer to 1 to 2%, less than 5% for sure. Busulfan would be the most common agent that causes this. There's this real classic triad, so weight gain, upper quadrant pain, and increase in liver enzymes. This usually comes on in the first month, which is not a great time because people are often sick with other symptoms. And so we're adding this on top of, severe mucositis and nausea and such, which is tricky. So we do prophylax all our patients that get busulfan with ursodiol, and then we'll generally give defibrotide as treatment if patients develop this adverse effect. There is a clinical practice guideline to guide this treatment, and then risk factors are associated with VOD. So history of radiation, prior chemo, prior stem cell transplant, and some of our newer ADCs like gemtuzumab, ozogamicin are associated with more VOD in the transplant setting. Going to kidney, so hemorrhagic cystitis is a adverse effect that we watch for, and we have built into the treatment plan prophylactic measures to prevent it. Up to 10% incidence. Again, it's going to be lower than that usually. Any dose of ifosfamide. So any dose of ifosfamide is going to be inpatient treatment and IV therapy required. High dose cyclophosphamide, and then we don't really use oral cytotoxin much anymore. But in the past, when we used it, over time, people that are dehydrated at home had issues with it. So we watch. We give prehydration. We give mesna to capture the deleterious metabolite, which is acrolein, and we check the urine every day for blood in the urine. So there's a UA in the Beacon treatment labs, and the onset will be relatively fast after this. Both ifosfamide and cyclophosphamide have pretty short half-life, so you're not going to see it after 48 hours usually. And this is what it looks like on imaging, really inflamed lining of the bladder. So again, here's the treatment. So we'll encourage a lot of fluid intake, mesna. I always use it with ifos. A lot of times we can get away without using it in things like CHOP and smaller doses of Cytoxan. But you got to monitor, can people tolerate this much fluid? Like ifosfamide is 200 mils per an hour. So, heart failure patient or somebody with respiratory disease may not be able to receive the therapy. And just to kind of hammer home the point on why ifosfamide is a challenge is that we generally give 5 times the dose of ifosfamide versus cyclophosphamide because 5 times is needed to get to the same level of active metabolite in treating the cancer. And so, but there's kind of a 1-to-1 development of acrolein after that. So it's 5-fold more toxic metabolite in acrolein than cyclophosphamide would be. So that's why we always give supportive care for ifosfamide. And here's just a slide showing that it's built into Beacon. The last kind of toxic, adverse effect we'll talk about in alkylating agents is renal toxicity. So this can be challenging. So there's a lot of different mechanisms. There is a lot of good papers on this and such, but it's hard to distill into one slide. But oxidative stress, DNA damage, inflammatory response, all lead to renal toxicity. And some of these doses can just be huge, 100 milligrams per meter squared and repeated over and over, in a sarcoma setting, for instance. And so they'll be, you're definitely going to see more kidney injury with higher doses of cisplatin, and definitely more kidney injury the longer you have to give cisplatin. So black box warning, 33% incidence. A lot of the patients will do fine week 1, so you kind of might rest on your laurels a little bit, but then the second week it'll really erupt. You'll see the serum creatinine just jump, and a bunch of electrolyte abnormalities. So magnesium, potassium, calcium will all be off. And so it's really unusual because a lot of times the patient were like, oh yeah, this seems to be going pretty well, and even at discharge the kidneys look good, and then week 2 in clinic it kind of deteriorates. So it is a lot of these patients, especially with kidney injury, will need magnesium supplementation. It's good to potentially schedule fluid checkups in clinic. It's good to watch closely week 2, not just check the labs one time if you're nervous about the patient, if they have risk factors. And those risk factors are listed there. So renal impairment baseline, older patients, those already taking NSAIDs, or we try to get patients off NSAIDs for cisplatin, but sometimes it's challenging. And then patients that well hydrated are they may be susceptible to substance abuse type such, and alcohol, and just not keeping hydrated. So important to watch closely. Renal dosing was not required when most of these drugs were FDA approved. And so we really only have FDA label dosing for the newer agents that were approved, post, essentially 1995 or so. There are some studies, a lot of these are really small, may only be 10 patients. So it's oftentimes a shared decision with, pharmacy physicians and even patients to understand what to go off of. Again, the black box warning is for ifosfamide, cisplatin. Then there's a warning for lomustine, cyclophosphamide, carmustine for renal toxicity. These keep searching the primary literature. There might be more updates on how best to renally dose these cases, but you'll see that a lot of them, cyclophosphamide, we almost never dose reduce because it really is cleared by a number of other mechanisms. So and oftentimes it's used in a curative setting. So if it's used in palliative or late stage, you might be more inclined to dose reduce. Now, hypersensitivity, we mentioned, I think it was 11 or 12 of the 15 drugs are associated with that. So it really is, IgA-mediated release of histamines, leukotrienes, prostaglandins, and it happens quickly, like within minutes usually, 15 minutes, I'd say, at most is most of the drugs. Carboplatin is the most common by far that we'll see this in. So the symptoms are the classic hypersensitivity adverse effect, IgA mediated, flushing, itching, urticaria, swelling. And kind of the key point, I guess, and I'll go over it on the next slide, is like you do kind of throw the kitchen sink at it initially, but then really focus on treating the symptoms. And even up front, if the adverse effect is mild, treating the symptoms is best instead of throwing everything at it. But we stop the effusion, get vitals, and then give PRN medications. That PRN medications are built into all these plans, so that's nice. We have 5 PRN medications built in. And then here, this guideline I'd recommend having access to. It's very helpful. I still use it. I don't memorize this, but like swelling of the lips and tongue, you treat slightly differently than shortness of breath. So yeah, you can, unfortunately the pulse is not great, but saving this or having access to at least this table one. Table one's the most useful part of the document. So I highly recommend it. I think the nurses do a great job of managing hypersensitivity. I think it's nice to have a team-based approach to this. And just remember, even any site you're at, kind of know where the emergency medicines are at. I know, like on the east side, we had some challenges with placement of blue cards early on in the opening a clinic. And so as UW Health kind of spreads more and more to different sites, make sure you know where these emergency medications are. And then carboplatin again, so it's very common to have hypersensitivity. I think we have probably 10 patients a year that end up needing desensitization. So with this tapering of dose, we can get through therapy. It will take hours. It's usually, I'd say 6 to 12 hours. Initially, especially, it's closer to 10 to 12 hours. Sometimes patients will have to leave the clinic and go to an infusion center or inpatient setting because the clinic's closed. So it can be a challenge there, but most people do pretty well on this, except for the really long day getting the drug. So there's a wide variety of dosage forms for alkylating agents. It's so intercavitary dosing, there's interarticular dosing, there's implant wafers for the brain, there's ophthalmic dosing. Intercavitary will often be used for pleural effusions. So thiotepa is been around a long time, a lot of development on these drugs. And then finally, just interactions are really tough to predict. It's tough to have these memorized. I often will have to look it up. It's important, and still with Paxlovid, the COVID medications, just remember oftentimes these drugs will have a longer half-life. So even though they might not have had it for 3 or 4 days, it's important to think about, is it still in the system or not, infecting those kind of drugs. Okay, a couple pointers on research. So the PRC is what UW uses for the that's the name of our investigational drug service, Pharmaceutical Research Center. Every single patient will have a yellow flag to indicate if they're a research patient. Pretty much every year, unfortunately, somebody will sign research orders that is not authorized to sign them. So be very careful. And generally, fellows are not always, but generally they're not registered. And then APPs will be for select trials, usually in their specialty only. And so just be very certain that you're enrolled to be able to sign the therapy. And then PRC is available 7 days a week, 7 to 10. Best way to get a hold of them is to page them. Tempus is our most common NGS, and just to kind of put, they'll generally have somatic fields on the top, potentially actionable, biologically relevant, and then germline at the bottom, and then immunotherapy markers, tumor mutational burden, microsatellite instability, and some people add on immunohistochemistry testing. Not all patients will have that. Tempus we use, I'd say, more than 80% of the time now. There are dozens of NGS companies. And then I would recommend getting the Tempus portal access. You can have it on your phone, website on the computer, to be able to quickly see your patient's data, even before it gets into HealthLink, although it has been getting into HealthLink much faster recently. But if you do not have Tempus portal access and you would like it, feel free to email me and I'll get you in touch with the people. So the medication section, so where pharmacy is kind of looking at, is FDA approved therapies, clinical trials, and then VUS annotations. Genomics resources, so our most commonly used one is OncoKB. The FDA keeps a site up to date with the different biomarkers. So all drugs with a biomarker notation in the package insert is listed on these websites. And then to dig deeper for actionability, or even sometimes we'll need insurance test claims, either ClinVar Bioportal. And we work with Precision Medicine Molecular Tumor Board as well, to kind of get more prior auth information. So OncoKB has, every year they add more genes every month. So 945 genes now. Of course, in humans, about 22,000 genes, 143 cancer types, 156 drugs. And so level 1, it's 55 genes there, but that covers 101 drugs, 39 cancer types. And then level 2, which is standard of care, and we have most of these standard of care treatment options at UW. That'd be 32 cancer types and 58 different drugs. So 156 drugs total have annotation now. The FDA table will show you exactly what it's looking at. So is it a somatic gene that is therapy related? Is it something that you're monitoring a diverse effect, or what exactly is in the package insert, essentially? So it's not always like this treatment is for therapy only. It's also for safety of the patient. So great resources to use. All right, antimetabolites. I'm running a little bit behind, so I'll talk a little faster here. Sorry about that. But methotrexate, first metastatic cancer cure, ALL, the first first non-metastatic and first metastatic cure. Pretty exciting at the time. Here we have 6 drugs that are given to more than 100 patients a year, and then 9 drugs that are given more than 500 doses per year. So these are more, used a little bit more than the alkylating agents. You'll see that 5-FU is the most commonly given of these agents, so almost 6,000 doses a year. Again, that's largely going to be in the GU setting, but also head and neck, breast, and GU. In general, these drugs work by either affecting an enzyme related with DNA, RNA metabolism, or affecting a building block of the DNA and RNA. So that's really kind of it. So that downstream will impact DNA synthesis and repair. It'll impact RNA translation. But really, all of the drugs work through one of those mechanisms. This class has 28 black box warnings, and so somewhat, kind of some overlap with alkylating agents, and then other new ones here. So neurotoxicity again is a higher adverse effect, again, as far as the number of adverse effects with either black box warnings or package insert warnings. you'll see hepatotoxicity is much more common in the metabolite class. Like the liver in general is just, it's very good at clearing alkylating agents. There's a lot of dehydrogenases that can cut those drugs and metabolize them to a inert substance, but not so much with the antimetabolites. So that you're going to see a lot more hepatotoxicity with these drugs. Myelosuppression again, so shares, all 12 of these drugs have myelosuppressive effects. A lot of these also have hypersensitivity, and we have to watch tumor lysis syndrome in these medications. Methotrexate, so this drug is universally fatal without, if it's given as a high dose, it's universally fatal without proper supportive care. So it's a super important drug to give safely. Methotrexate has 14 black box warnings, the highest of any drug on the market. And so it's very like we have a lot of work around this and a lot of supportive care and a lot of education and teaching on methotrexate every year. So it works in a couple different mechanisms. So it's it blocks an enzyme. So it blocks actually two enzymes that build the building blocks for DNA and RNA. So, and really it works both intracellular and internuclear. So it works at different spots, and that's why you have to really kind of compete with it for leucovorin to recover the leucovorin rescue, essentially. So oral and IV, so large dose range, 5 milligrams weekly for arthritis, all the way to 12,000 milligrams per meter squared for sarcoma. There's onc and non-onc indications. You will, like the fellows, will end up getting heme consults on methotrexate patients that are on it for a non-oncology indication. And then high doses greater than 500 mg per meter squared, all of those patients will be admitted. And then we have a clinical practice guideline for high dose methotrexate. So if you ever administer it, make sure to have that handy. So delayed methotrexate clearance can lead to many adverse effects. The risk factors are baseline renal dysfunction, third spacing. And so a lot of times if we're worried about third spacing, we'll end up getting an X-ray just to make sure there's not like a pleural effusion or anything if someone is short of breath. Hepatic dysfunction, low albumin, dehydration, morbid obesity, and age. And we really saw with obesity that like this is a slide from our patients, and larger BSA patients definitely had more renal toxicity. There's a lot of drug-drug interactions with methotrexate, so every time that's reviewed by pharmacists when we're verifying the medication, a lot of times we'll have to hold stuff. Probably the most common is pantoprazole will have to be held. And here's our platform. So this is all built into Beacon, and so we're checking urine pHs at intervals, so -4, 0, 2, 4, 8, and then every 8 hours after. And pharmacists are writing daily PK notes if needed, always at 24 hours. And we follow with leucovorin adjustments, and you can see the algorithm here. So it's over time, 24-hour level, 36, and then 48 or 42 and longer. And leucovorin doesn't increase methotrexate clearance. Doses like bigger than 25 need to be IV, and then we continue until methotrexate is at least less than 0.1. And then if there is overexposure, which does happen, like we've used glucocorticoids 6 times in the last 5 years. So this is kind of an antidote for antimetabolites. We have ability to get glucocorticoids. This is all kind of spelled out in the guideline, and oftentimes even though I wrote the guideline, I'll go back and look at this again. Essentially, there's several things you have to follow. You have to hold leucovorin for a certain amount, otherwise glucocorticoids will just chew up the leucovorin instead of the methotrexate. We do stock 2 vials of this in-house, which is really nice. We generally dose cap it. and then it's difficult to retreat this disorder. So it's important to get it right the first time. All right. So in the antimetabolite section, there's more supportive care specific to the certain drugs. So I'll send these slides out and such, but the supportive care specific to the drug is listed here. So pemetrexed, we do both folic and B12 supplementation. We don't do that for methotrexate. All right, going on to purine analogs, so 6-MP metabolism. Xanthine oxidase is metabolizes to inactive metabolite, and there's a major drug-drug interaction with allopurinol. So you have to reduce 6-MP by 75%. We generally try to not give allopurinol. This is in the consolidation setting. It's not in induction. So patients' risk of tumor lysis is often very low. So we will usually get rid of that. So it's TPMT. There's intermediate risk here. So this is a genetic component that's a safety issue. Poor metabolizers need to have their dose of 6-MP reduced tenfold. We check this polymorphism for every single patient that we give it to. You can see in the lollipop diagram on the bottom that there's a lot of variance for TPMT. There's no there's not one that's a dominant variant like there will be for other drugs. So it's important to it's a little bit more complicated test essentially to look at. And so if you are a mutant, your myelosuppression will be very severe and the risk of secondary cancer will go up dramatically. Okay. And then pyrimidine analogs. So one thing to look at here, I know Liz talked about capecitabine adverse effects and how to manage that. I just want to quickly mention the genomic component. So DPYD, if you have a deficiency, the metabolic, like the 5-FU is not able to be metabolized to a inactive metabolite, and severe toxicity builds up. And so full deficiency is rare, 0.01 to 0.2% of people. If this happens, cytopenias, mucositis, diarrhea. Been here about 18 years, and I've seen 2 cases of this that we were able to get through with supportive care, but it was, it was ICU level stay. It was very sick, very bad adverse effect. And so ideally, we'd prevent this with everybody. And someday soon, I believe we will have, testing available for everyone. As of now, though, it's still a relatively high cost test. January of this year, the FDA did announce that it's very important to discuss DPD deficiency with your patients prior to giving capecitabine or 5-FU. And so generally, you can kind of default to the providers in clinic and such, but usually it's a discussion about relatively low risk and reporting symptoms up front. Due to the cost, which is still about $700 cash price right now, and insurance is not always covering. It can be tough. It's a tough discussion to have with a patient. Obviously, you don't want to be one of these full deficiency patients and get this drug, but it's important to have the discussion, and there'll be more to come on over time. Like this is just one example of how we're getting more genetic details on adverse effects, but it's difficult to operationalize that for every patient still. So the dose reductions are in the package insert, so I always go there for both 5-FU and CAPE. And then there is also an antidote for 5-FU. So occasionally a pump will fail, or it will be deliver a dose that's supposed to be given over 46 hours within 2 hours. And we have a drug to treat that. This reduces incorporation of the altered DNA building block into RNA. And so it helps with the GI mucosal and normal tissues. This medicine is so again, like if this happens at the VA, or if you're in Rockford for some reason, the best case is to get this patient to UW as soon as possible, and also let us know that we need to order the drug. We do not stock this. The drug comes from Memphis, Tennessee, and so it usually takes about 12 hours to get here. We'll almost always start it as soon as it get here. Most of the time, it ends up being 1 or 2 in the morning that it's started. The faster you can start it, the better. But these kind of remote sites are not going to have access to this drug or knowledge of how to order the medication and get it started. And almost everyone's going to be on GCSF as supportive care to help their neutrophil count. This is a rare use drug, but 2 patients in 5 years. And actually, the last time we used this was the first month of a new fellow starting. So they had to, and it was a VA patient, so it was somebody that was outside of UW Health, and any delay to get to this drug is bad. So get it as soon as you can. Considerations for these agents are listed here. And yeah, cytarabine, which is one of the most commonly used drugs, mostly in the heme setting. But rash onset 5 to 14 days is probably the most common adverse effect, maculopapular upper body in nature. And then high dose requires neuro exams. And as of now, we still admit patients for high dose. Some other centers will watch closely at a hotel locally, but we don't have that capability yet. Last set is hypomethylating agents. So both azacitidine and decitabine are among those that are used more than 500 times per year. Aza, we watch the bicarbonate level, renal impairment. So it's important to watch that BUN. You'll see, go to 100, 150 even, and then generally it'll get to baseline within 28 days, but not always. So we have had to dose reduce some patients. Decitabine, same thing. It can cause renal toxicity, but also liver toxicity. You don't really see liver toxicity with azacitidine. And we prefer to give azacitidine sub-Q because the IV formulation is only stable for 1 hour, and that can be very difficult to make it in central pharmacy, get to the floor, coordinate with the nurse to give it within 60 minutes. And a similar drug-drug interaction profile for these medications. And also metabolites in general are a little bit newer, so there is more renal dosing and hepatic dosing in the package inserts, which is nice to have. The genomics stuff is listed on the side there. Yeah, MTHFR, if we have a severe toxicity from methotrexate, we'll look into that, but we generally won't look at it up front. And it's still not really proven to be associated with toxicity. But TPMT, we check for every single patient that gets either mercaptopurine or thyroguanine. DPD, there's that discussion with the patient. Do you want to get the testing? What are the risks for capecitabine and 5-FU? And what should we be watching closely at home? And that's the talk. So I appreciate the attention today. And if any questions, I have a minute here. Otherwise, I'll feel free to email me. My email's at the bottom there.